Okay, thank you. Thanks for the introduction. I'm Daniel from Perth. And first of all, I would like to thank Professor Colonge for inviting me and for arranging this visit and this talk. And I was really impressed by the amazing work that's being done here. And it's been a pleasure to talk to different people and get to know the Institute and what's being done. So I will be talking about how we use stem cell therapy to regenerate the ocular surface in patients with ocular surface disease, mainly with limbal stem cell deficiency. Before I start, I don't have any conflict of interest about this talk presentation today. So first of all, let's see what's the ocular surface. So the Tear Film and Ocular Surface Society defines the ocular surface as a complex structure that includes cornea, conjunctiva, the tear film, the eyelids, eyelashes, lacrimal glands, and meibomian glands. And in more recent definitions, they also include the innervation system, afferent and efferent innervation systems, which control all of these functions. Corneal epithelium is one of the most important parts of the ocular surface that provides a protection against the external factors, and also it maintains corneal clarity. And as we know, cornea has to remain avascular to provide optimal vision, and corneal epithelium is one of the factors that contributes to maintaining corneal avascularity and clarity. And like any other epithelium in the body, corneal epithelial cells also are replaced with new cells every day, and it takes 10 to 14 days for the whole corneal epithelium to be replaced with new cells. So everywhere that cells are being replaced with new cells, we need stem cells. And the stem cells in the cornea are called limbal epithelial stem cells. These cells are located in the corneal periphery, 360 degrees, and mainly are populated in the superior and inferior limbal region. And as you can see here, limbus is the area between the cornea and the conjunctiva, and the limbal epithelial stem cells are located in the basal layer of the limbal epithelium. We also have a very important structure here called limbal niche that provides support for limbal stem cell proliferation, differentiation, and migration towards the corneal center to differentiate into more differentiated corneal epithelial cells. So all of these structures are really important for a normal function of the limbal stem cells and for corneal function and for corneal clarity and finally a good vision. So if any of parts of this system doesn't work well, we have a condition that's called limbal stem cell deficiency. There's a very long list of the reasons that why someone can have limbal stem cell deficiency, but overall it can be congenital or caused by genetic mutations. One of the most common reasons is congenital aniridia. You can see this iris defect here, and also the corneal opacification and vascularization. There are also other congenital reasons like epidermolysis bullosa, like ectodermal dysplasia, and multiple endocrine neoplasia. But in most countries, chemical burns are the most common reasons for limbal stem cell deficiency. It can be unilateral or bilateral, caused by acids or alkali, or also it can be caused by thermal burn, as well as chemical. Also, Stevens-Johnson syndrome is another condition which sometimes is caused by a reaction to a medication and sometimes to a viral infection. And it's a generalized immune response that also involves ocular surface and causes limbal stem cell deficiency. In Iran, where I practiced, we also had this condition, mustard gas keratopathy. Mustard gas was used as a chemical weapon during the Iran-Iraq conflict, and we had hundreds of people who were exposed to mustard gas. And one of the main characteristics of mustard gas exposure is limbal stem cell deficiency, and most of these patients needed limbal stem cell transplantation, and we had a clinic dedicated to these patients, and that's why every week we had 10, 15 patients with this condition coming to us. There are also other etiologies. it can be caused by us through medications like mitomycin C we use for different surgeries. Or if we do repeated surgeries on the ocular surface that involves the limbal region, it can also result in limbal stem cell deficiency. And sometimes also if the patient wears soft contact lens for a long time, it can also lead to limbal stem cell deficiency, bilateral or unilateral. And any other type of chronic ocular surface inflammation, like in atopic conjunctivitis, or also mucous membrane pemphigoid, are other causes of limbal stem cell deficiency. But the list is even longer than this, but these are the most important reasons. So why is limbal stem cell deficiency important? What are the consequences of limbal stem cell deficiency? In general, it can result in two separate scenarios. So if the damage is not very widespread, so the conjunctival epithelium still can regenerate and cover the corneal surface, then there's a condition called corneal conjunctivalization. As you can see, if it's localized, then we have partial limbal stem cell deficiency, partial conjunctivalization. In more severe cases, it can be total. Or if it's very advanced, then the lipid deposition can cause deep stromal opacification. And if the damage is very severe, then conjunctival epithelium also is damaged. It cannot cover the corneal surface. So we have persistent epithelial defect, which if it's not treated, then it can cause corneal melting, thinning, perforation, and severe infection, which can result in permanent blindness. So it's important to address limbal stem cell deficiency promptly. How we diagnose limbal stem cell deficiency? It's mainly clinical, based on history and clinical examination. We might see this whorl-like epithelial pattern, which shows the presence of conjunctival epithelium on the cornea, which is abnormal. Or we may have superficial vascularization, and also late staining, which is typical of the conjunctival tissue on the cornea and a sign of limbal stem cell deficiency. If for any reason we are suspicious and we don't know if there is a limbal stem cell deficiency or not, we may use impression cytology, which is very helpful in diagnosing limbal stem cell deficiency. If we see the goblet cells on the cornea, this is a definition of limbal stem cell deficiency, and this is the most useful test in the clinic if we have any doubt about the diagnosis. We can also use in vivo confocal microscopy and anterior segment OCT, but they are not as specific and sensitive as impression cytology. And there are two main conditions that we have to differentiate from limbal stem cell deficiency. One is corneal vascularization due to other causes like infections. They can cause vascularization without limbal stem cell deficiency. And also corneal intraepithelial neoplasia, which is a neoplastic disease. So both of these conditions can be differentiated from limbal stem cell deficiency with impression cytology, so we can diagnose it. Before going to the treatment, we need to evaluate and classify the limbal stem cell deficiency so we can choose the best treatment. So the most important question we usually ask first is it bilateral or unilateral? It changes the whole scenario and the whole treatment strategy. Is it total or partial? And what's the underlying etiology? If there is an inflammation, is it ongoing inflammation, like as I said in mucous membrane pemphigoid, or is it the inflammation is controlled, like an old chemical burn? And also it's very important to look for other ocular surface comorbidities in the eyelids, eyelashes, fornices, and tear film. And also we need to evaluate whether the eye has a potential for vision. So if we have a, say, like retinal detachment or optic nerve atrophy, then there's no point in treating the corneal condition. So we need to evaluate the eye condition before deciding what's the best treatment. And for the management, we have conservative solutions like just ocular lubrication using anti-inflammatory medications just to control inflammation and prevent further damage. We can also, sometimes we need to do other surgeries before a definitive treatment, like if there's any abnormality in the eyelids or eyelashes or in the fornices, we need to treat them first. But in most cases with limbal stem cell deficiency, the definitive treatment is stem cell transplantation. So I would like to go through a few cases to see what are the options for the treatment of limbal stem cell deficiency. So the first case is a young male with chemical burn in one eye. Right eye has a counting finger vision, which is this one, and the left eye is normal with 10/10 vision. And with a diagnosis of total unilateral limbal stem cell deficiency, overall the treatment of choice is autologous contralateral limbal transplantation. So what we did in this case is we borrowed, or we took two large limbal blocks, 60 degrees each. So we have 360 degrees limbus. So we take two 60-degree blocks, which overall is 1/3 of the limbus. And then we transplant this to the diseased eye. And this procedure is called conjunctival limbal autograft, which was done by Kenyon and Seng in 1989 for the first time. And this is the same eye after 3 months. You can see some of the vessels have regressed. The eye surface looks smoother, and because the vision was still counting finger, we did penetrating keratoplasty or corneal transplantation, which is an optical treatment. And this patient, after 6 months, had a 4/10 vision, but it could be better after we remove the sutures, and maybe with a correction could be even better. So this is the process of growing the epithelium from this limbal block from inferior and superior sides. So you can see that the epithelium is moving towards the center after 3 days, and after 8 days, the epithelial defect is almost healed. The second case is again a unilateral chemical burn. This time, left eye is the diseased eye, which is counting finger vision, and the right eye is normal, 10/10 vision. Again, with the diagnosis of unilateral limbal stem cell deficiency, again, the treatment of choice is autologous contralateral limbal transplantation. But this time, so this picture was taken after the first procedure. This time, instead of two 60 degrees limbal block, we took a very small limbal biopsy, and then you send this limbal biopsy to the laboratory. They grow it on a membrane, which is usually a human amniotic membrane. And then once the epithelium has covered the whole surface of the membrane, then you transplant it on the eye surface. So this procedure is called cultivated limbal epithelial transplantation. Cultivated is the same as cultured, so, or CLET for short. And this was first done by Pellegrini and colleagues in 1997, and then later got Euro approval in a product called Ocular. So in our patient, after 2 weeks, the vessels have regressed and the cornea become a bit clearer. And then after 2 months, this patient had a 1/10 vision. Depending on the patient's need, you might decide to do penetrating keratoplasty or corneal graft. Or if the other eye is normal and the patient doesn't need a better vision, then you can just leave it as it is. So in summary, what's the difference between CLAU and CLET? So some patients have concerns about the safety of the donor eye, because so that's their better eye. And then if you take 1/3 of their limbal stem cells, they might be concerned about the safety. It's pretty safe. It's proven that it's a safe procedure if it's done properly. But still, CLET is a better option if safety is a concern, especially if the donor eye, the other eye, like say in a chemical burn, if you have one eye with total limbal stem cell deficiency and another eye, the other eye is suspicious. You don't know if they had any exposure to chemical injury or the patient is a bit unsure, then CLET is a better procedure compared with CLAU. With CLET, we can do multiple procedures. So as you see, even if you remove 1/3 of the corneal limbal stem cells, it still can function. So you can repeat CLET. If the first procedure fails, you can repeat CLET. Or even after CLAU, it fails, you can still do CLET because we need a very small biopsy for cultivated limbal epithelial transplantation. And the other difference is the cell phenotype, because with the CLET, it's a cultivation technique. We culture the cells, so we are proliferating limbal stem cells. So at the end, you have limbal epithelial phenotype on the corneal center. But with the CLAU, you put the blocks on the corneal periphery, so only the differentiated cells move to the center. So that's another difference between CLET and CLAU. And probably the biggest difference, which is not very good for patients, that CLET is a 2-stage procedure. So the patient has to come to operation room one time. You take the block, the sample, and send it to the lab. After a few weeks, they have to come back and do the second procedure. But CLAU is a one-time procedure. The third case is, again, so they're all male. As you know, this is the main cause of chemical burn is work-related injuries, at least in Iran. So they're all males working with chemicals. So this patient had, again, a left eye chemical burn, total limbal stem cell deficiency in the left eye and the normal right eye. But this time, so the procedure that we developed in our center in Iran was that instead of sending the block to a laboratory to grow it on the membrane, we transplanted the block onto the diseased eye, which is here, and then asked the patients to put a drop, which is the extract of the amniotic membrane. And we called this procedure in vivo CLET because we do the culture in vivo on patient's eye. And after, we had to do, so after 4 weeks, you can see how the eye changed. The vessels regress. You see the very nice epithelium. And then we did the penetrating keratoplasty, corneal graft. And after 3 months, this patient had a 6/10 vision. And we did it in 14 eyes, and out of these 14 eyes, 11 of those 14 eyes functioned very well until 12 months. So we did a assay of the amniotic membrane extract eye drop. So there are a lot of factors, but these are the main factors. As you can see, there are lots of growth factors and also anti-inflammatory factors in the amniotic membrane extract eye drop. And also, we showed that with this 0.5 milligram per milliliter concentration, we got the best results. So that's the concentration that we used in our patients. And these are other examples of the same procedure. Did amniotic. So this is the same patient, but this is another example. And this is how the epithelium. So here, this one shows the epithelial defect after the procedure, and after 2 weeks, the epithelium is fully recovered. And again, just like CLET, which we saw limbal phenotype in the corneal center, with this procedure as well, we saw limbal phenotype in the corneal center because we cultured the limbal epithelial stem cells on the eye. So you can see P63 is the most widely used limbal stem cell marker, and at the moment it's the best marker. And we also, CK3 is a corneal marker. We showed that those patients who have been treated with in vivo cultivation, they expressed P63 and CK3 in the corneal center. So when we did the corneal graft, we took the patient's cornea with the cells on it and did this analysis. And also RNA expression levels showed that limbal stem cell marker P63 was expressed in the patient's corneas compared with control corneas. So to review all these procedures, for unilateral limbal stem cell deficiency, we have conjunctival limbal autograft, which is because autograft, we don't have any rejection, we don't need immunosuppression. It's safe for the donor eye, but if there's any safety concern, we can do cultivated limbal epithelial transplantation or ex vivo CLET, or alternatively we can do in vivo CLET. In both of these procedures, we are culturing the cells. So this is a schematic view of how we transplant this small block to the diseased eye and then provide amniotic membrane extract eye drop to culture those cells on the eye. So the main advantage of in vivo CLET is that it's a one-step surgery. As I said, with the CLET, they have to come back after a few weeks for the second surgery, but with this in vivo CLET, we don't need the second procedure, so it's the same thing. We just culture the cells on the eye. This is another procedure called SLED, or simple limbal epithelial transplantation. It was invented by Sangwan in 2012. I have never done this personally, but instead of transplanting the limbal block, you cut it into a lot of smaller pieces and then put it on the cornea, and they have reported favorable results with this procedure as well. And now let's see what if the damage is bilateral. So both eyes are damaged and they have counting finger vision like this. And then with the diagnosis of bilateral total limbal stem cell deficiency, we don't have a normal eye to borrow the stem cells. So we have two main options. One is that we get the stem cells from a donor, a deceased donor, which is died, and from the eye bank. So this procedure is called keratoליmbal allograft, or KLAL, which was first time done by Holland in 1995. Because keratoליmbal allograft needed a very high dose immunosuppression, they first thought that maybe if they get the graft from a living relative, like one of the family members who has a matched immune system HLA antigens, maybe they can reduce the risk of rejection. So they invented this procedure called living-related conjunctival limbal allograft, or CLAL, which was invented by Sobota in 1999. But later they realized that even if it's a family member, they're still going to reject the graft. So with this one, because the patient is a living donor, so you put the donor eye on a risk. So that's why still keratoליmbal allograft is the first option for these cases. So in our center, we used to do a 360 degrees corneoscleral rim, which, as you see, includes the limbus. But there are different modifications of this procedure depending on the center that you train. So we suture the sclera to the sclera, and then after 3 weeks, you see all the vessels have regressed. And in this case, because the vascularization and opacification was superficial, after 3 months, you can see that the cornea is almost clear, and the patient had a 310 vision and didn't need an optical procedure or a corneal graft. But most of them still need an optical procedure or corneal grafting. And the last case in this part is, again, a young male with both eye chemical burns. But this time, as you can see, there is lipid deposition, and it is a more severe case of limbal stem cell deficiency, again with bilateral total limbal stem cell deficiency. So there are some cases that allograft we can't take sample from a donor eye for several reasons. Some of them, so the patient, if they are very old, they can't tolerate immunosuppression because it can cause organ damage, or if they already have a systemic disease and they can't tolerate immunosuppression, or you don't have access to a high-quality donor for keratoליmbal allograft. So in these cases, there's another procedure called cultivated or cultured oral mucosal epithelial transplantation, or COMET, which was first done by Nishida in 2004. And in this procedure, this is almost like CLET, which we take the sample from the oral mucosa, we send it to the lab, they grow it on the membrane, and after 2-3 weeks, they send us the membrane which has the oral mucosal cells on the membrane. You can see the sutures here. The membrane with the cells is sutured to the limbus. And then after 2 weeks, again, you see some of the vessels have regressed. The epithelium looks better. And then we did the penetrating keratoplasty or corneal graft. As you can see, after 3 months, the cornea is almost clear, not as clear as corneal epithelium. And that's the main problem with COMET, because it's oral mucosa, it's not a corneal epithelium. But when you don't have any other options, that's one option that you can do for patients. And these patients had a 310 vision with all those sutures. So we reported 2 years outcome of 14 cases with corneal graft after COMET, and 13 of those 14 cases had a good vision still after 2 years. In one of them, it failed. And so these are other examples. So this is one example of partial failure. As you can see, the peripheral vessels are growing into the cornea, which shows that the stem cell graft is failing. And so in summary, for bilateral limbal stem cell deficiency, we have keratoליmbal allograft and we have COMET. This is a schematic view of how we take the sample from oral mucosa and send it to the lab to grow on the membrane. And these are other examples. As you can see with COMET, the corneal epithelium is never as clear as the original corneal epithelium. So for end-stage cases, so if it's bilateral, we've done all of those procedures, they failed, and there are other options which are artificial cornea or keratoprosthesis. So this is one example which was developed in Boston by Dolman. This is type 1, which is for when the ocular surface is not severely damaged. This is another one which is for more severe cases, and this is called type 2 Boston keratoprosthesis. And then this was invented first time in Italy by Pintucci, and then there were some modifications of this method, which is probably one of the oldest devices. So as a summary, I didn't talk about the partial limbal stem cell deficiency because sometimes they don't need regenerative treatments. So sometimes if you just remove the conjunctival epithelium, the limbal stem cells from the rest of the cornea can recover the epithelium on that side. Or if you have a big mass or tumor on the limbal region and you have to remove it, you can borrow some stem cells from the same eye and transplant it, so you prevent limbal stem cell deficiency. But the main problem is with total limbal stem cell deficiency, if it's unilateral. So we had conjunctival limbal autograft, we had CLET, and we had a SLET. So CLET could be ex vivo or in vivo. And if it's bilateral, the first option was keratoליmbal allograft, then living related, and COMET. Alloclet is another option. Again, I've never done that. And keratoprosthesis is the last option in all of these cases. But you see, so we have lots of options, but we're still not quite there. So we still need more methods for treating limbal stem cell deficiency. As I said, with the keratoליmbal allograft, especially for bilateral cases, it's very invasive, it needs immunosuppression, and sometimes the high-quality donor is not available. With COMET, the long-term outcome is questionable. The cellular phenotype is different. It's not as clear as cornea. And if the patient has mucosal pathologies like in Stevens-Johnson syndrome or mucous membrane pemphigoid, that's not a good option. And with the keratoprosthesis, that's the last option, but still, because sometimes it's not biocompatible, it doesn't integrate in the ocular tissue, they can extrude very easily, and they can cause infection and other complications. So this is one study in our center. We studied 60 patients with limbal stem cell deficiency, and as you can see, because of the rejection, the rate of rejection and failure is much higher in those who had keratoליmbal allograft compared with CLAU. So for the future treatments, we need other stem cell sources, because if it's bilateral, we don't have a limbal stem cells, and we need new stem cell sources that are preferably autologous. I know Marga is not a fan of autologous stem cells. They must be accessible, and they have to be able to produce corneal phenotype. And we also need a substrate or carrier or a membrane to deliver the treatment. That needs to be biocompatible, non or low immunogenic, and also ideally support healing. And also, there's also advancements in gene editing. For genetic diseases, we can do gene therapy, which has to be safe and efficient. And also, there are some gene modifications for allogenic transplants, like for alloclete or allogenic stem cells. We can manipulate those cells so that they don't induce immune reaction. So these are some of the available stem cell options. We have embryonic stem cells, we have induced pluripotent stem cells, hematopoietic stem cells, and mesenchymal stem cells. I know you've heard a lot about mesenchymal stem cells, and they have been shown to be very effective in treating ocular surface or stem cell transplantation from different sources. But in our center, we focused on induced pluripotent stem cells that I will just talk a little bit more today. So as you know, induced pluripotent stem cells, as it's obvious from their name, they are induced, so they are created by us. So they're not stem cells. They are blood cells or skin fibroblasts. And I haven't included here, but Yamanaka, I don't exactly remember the year, but he found out that if you introduce those factors which are called reprogramming or pluripotency factors, OCT3, 4, SOX2, c-MYC, and KLF4, you can reprogram adult cells into stem cells. And they then can be differentiated into different lineages and different cell types. And they also can be used for disease modeling and drug discovery. So far, induced pluripotent stem cells have been differentiated in so many cell types, and including in the eye into RPEs, into photoreceptors, retinal ganglion cells, and also corneal epithelial cells, endothelial cells, and keratocytes. So iPSCs can be autologous. We can take the cells from patient's own body, from skin or blood, or can be allogenic again. So they have been shown to be safe. This is a clinical trial just published last year in Japan. They have treated 4 patients with limbal stem cell deficiency and followed them for 2 years. So these are all allogenic iPSCs. So they had to use immunosuppression for these patients, for 2 of them. So they've done immune matching for the other 2 patients, and they didn't use immunosuppression. And after 2 years, they showed that it was safe and it was efficient. So their protocol was published in 2017. I can't go into all the details, but this is a very sophisticated, long protocol. As you can see here, it takes more than 13 weeks to make these cells, and then it's very sophisticated. It needs a lot of methods and devices, like cell sorting, and then after doing all of this, they cryopreserve the cells that are differentiated from iPSCs, and then when a patient comes in, they take the cells, they seed the cells on a membrane, and then transplant it to the patient's eye. But as I said, this is a lengthy and complicated procedure. But then Hangisto and colleagues, they published the other protocol, which takes less than 4 weeks for fully differentiate iPSCs into limbal epithelial stem cells. When I started working on iPSCs, I saw this paper first, and then I started setting up the lab and doing this. And that was when I met with Michael Edel in Barcelona. So he came to Perth, and so we started collaborating and sharing our experience. So this is the protocol that they use in their lab, and they've shown that with a synthetic mRNA, which is a safer method of reprogramming and turning adult cells into stem cells without inducing mutations. And they showed that those cells have the capacity or ability to differentiate into mesoderm, endoderm, and ectoderm. And with that protocol, we differentiated those cells into limbal stem cells and showed that after 2 weeks, more than 80% of those cells expressed p63, which is a limbal specific marker. And then we grow those cells on fibrin membranes and transplanted into rat eyes. And in 3 rat eyes showed that it can regenerate the corneal surface. But we need more optimization and more experiments with this method. And so we followed that protocol, and we also used the other protocol, and we modified the old protocols, and then we did it in our lab. Again, we saw that after 10 to 15 days, the cell morphology changes to more human corneal epithelial cell lines, and most of them express ABCG2 and p63 alpha, and also CK18, which is a primary epithelial marker, and CK18 primary, and CK3 differentiated corneal epithelial marker. And our quantitative PCR showed that at day 10, we had the lowest pluripotency markers and highest limbal epithelial markers, and so that's why we decided to use those cells at day 10 to further our experiments. If you can see like this average. So the OCT4 and nano, they are pluripotency markers, but they are also expressed in limbal epithelial cells, even in human eyes. So we don't worry about them being OCT4 positive, but if they create a iPSC colony, then it's concerning, and we need to further optimize our protocols. But one thing that was interesting, that in human embryology, when the ocular surface is being made, so they first express cytokeratin 18, which is a primary simple epithelial marker, and later they express cytokeratin 14, which is a stratified epithelial marker. And in our differentiation process, we observed that at day 5, K18 was the predominant cytokeratin, and at day 10, cytokeratin 14 was the predominant, which also follows the embryological differentiation of the limbal stem cells. And then we also showed that if you double stain it so delta NP63 is a more subspecialized marker for limbal stem cells, and when we stained with delta NP63 and Ki67 is a proliferation marker. So we could show that more than 50% of cells were positive for both delta NP63 and Ki67, which showed that those stem cells are also proliferating. So then we decided to move to the next step. As I said, all of those steps still needs optimization and further experiments. But at the same time, we moved to the next step and decided to grow those cells on the amniotic membrane, which is a standard scaffold for limbal stem cell transplantation and culture in human. We use it in the clinic every day. And the human amniotic membrane is very accessible, it's biocompatible, it has anti-inflammatory properties, it's anti-angiogenic, it's non or low immunogenic, and it also promotes healing. So in our experience, amniotic membrane can also act as a niche. As I mentioned in the beginning, that niche is also important for supporting limbal limbal stem cell proliferation. So human amniotic membrane can play that role for us. So we got the amniotic membranes, we cut them into smaller pieces depending on the culture wheel that we wanted to use, and we removed the epithelium. And then we started the experiments. We saw that after removing the epithelium, the cells don't attach very well to the membrane, so that's why we stained for the laminin and saw that after removing the epithelium, the basement membrane of the amniotic membrane is also altered, so we decided to coat the membrane with laminin first and then seed the cells. So we had these cells at day 10 that are p63 alpha positive, and we seeded them on laminin-coated amniotic membrane, and after 3 weeks, we saw these p63 alpha positive and CK3 positive cells on the membrane. And this showed that we have grown those cells, iPSC-derived limbal epithelial-like cells on the amniotic membrane. And this is also a histologic section of the denuded membrane with laminin without cells. And this one is after growing the cells on the amniotic membrane after 3 weeks. So in summary, so we took the skin fibroblasts, we reprogrammed them into iPSCs, and then according to that protocol, we used a 4-day protocol for inducing those iPSCs, guiding them to become ectodermal cells. And then from that stage, we used a keratinocyte serum-free medium, which is not the original medium. We couldn't access to it at that time, but we need to work with the original medium later. And so after 3 weeks, we had these limbal epithelial cells and then grew them on the membrane for future transplantation. So as a overall context, we believe that we could successfully obtain limbal epithelial cells from iPSCs that were made from skin fibroblasts, and we grew them on the membrane, and now we are at the stage that we are going to transplant those membrane with cells in a preclinical model to test its safety first and then the efficacy in that model. I think that's the end, and I would like to thank my mentors, Sam, Mike, Glenn, Fred, and Bill, and these are my colleagues. So Professor Chen he is a retina specialist, and he has this whole lab, and they have all the culture rooms, and they are doing iPSC in retinal degenerations. They are doing some clinical trials with gene therapy for RP11 and some other forms of RP. But I'm the only, myself, and Caitlin in the middle, the only ones that are working on corneal regeneration, and we're hoping we can grow our team. And thanks for listening. If you have any questions, I'm happy to answer. Thank you.